hello to everyone joining us this afternoon. We're very pleased that you can come along. This is part of our awareness month. Our awareness month theme is focusing on cognition and thinking with Huntington's disease. So there's this webinar, and there's also a webinar next Tuesday. Just to plug it a little bit, Jimmy Pollard, who some people may be familiar with, who's the author of the book Hurry Up and Wait. So make a start on just a little overview of some of the cognitive aspects of Huntington's. Really, this is just an explanation as to why we called this webinar The Invisible Challenge, which might seem a bit of an odd title. Invisible, really, we're using that word because obviously you can't see cognition, but we know that cognitive changes for people with Huntington's can have quite a profound effect on our ability to function. And the challenge side of that is because it's hidden, it presents a challenge both to the person with Huntington's and to those supporting them. This is just a little reminder, and some people on this call may well be familiar with this idea. With Huntington's, we talk about a triad of problems, and all that means is there's three aspects, three groups of symptoms that people with Huntington's might encounter. So it's physical symptoms, it's thinking symptoms, so cognitive symptoms, which is what we're going to talk about this afternoon, and it's mood and behavior symptoms. And what we know is sometimes it can be quite hard to unpick when there's an issue, whether that person with Huntington's is having a physical problem, or is it something to do with their mood, or is it something to do with how they're thinking? And sometimes something that maybe looks like a physical problem might actually be something to do with, might actually be a thinking problem. Just to give an example of what I mean, if, for example, someone with Huntington's stopped eating, you might think, well, that's a physical problem. Maybe it's something to do with their swallow, but actually it could be a thinking problem. It could maybe be something along the lines of that person sitting down to eat a meal and maybe not isn't able to initiate that task, not being able to start that task off. So it could actually, although it looked like that might be a physical problem, it could actually be a thinking problem. Yeah, this is just a bit of a reminder about what happens in the brain when you have Huntington's disease. On the left-hand side, there's a brain of someone without Huntington's, and on the right-hand side, there's a brain of someone with Huntington's. And as you can see, the brain of the person who has Huntington's, brain matter has been lost. And if you look on the non-Huntington's brain, there's an area called the basal ganglia, that grey area there. And if you look on Huntington's brain, that area is really atrophied. And because of the damage done to that part of the brain, that brings about a lot of the symptoms that we see with Huntington's disease. That part of the brain, the basal ganglia, contains various structures that are involved in passing information on. And what we know is because of the damage that's caused, that information sometimes doesn't get passed on as it should do. And that then leads to a lot of the thinking changes that we see in Huntington's disease. So just to go through a few, this isn't an exhaustive list of things that happen in terms of people's thinking, but these are some of the main issues that people might encounter when they have Huntington's. So as I mentioned just before, getting started on things, so initiating tasks, it can get difficult for people with Huntington's. So someone with Huntington's might be able to do a task once they get started, but it's that initial thing, it's that getting going that can get really difficult. Because of that, we know that things like prompts and reminders can work really well, or working jointly with people to get going on a task. We know that multitasking can be difficult. I think multitasking is probably a little bit of a myth. What we're doing really is flicking our attention really quickly between two different tasks. And we know in Huntington's disease that thinking can start to slow down. So flicking attention between one thing and another thing can get really difficult. So that's why when someone has Huntington's, they might start to struggle. For example, even something along the lines that if you're walking along with someone with Huntington's and you ask them a question, you might well find that they stop to answer that question, and then once they've answered it, start walking again, because doing those two things, walking and answering a question, are two different tasks, and it might be that it gets too much to do those two things at the same time. We know that people with Huntington's, when they start to become symptomatic, can start to struggle with change. So that's anything that's unexpected, anything that person wasn't thinking was going to happen that suddenly does happen, can be difficult. And this really connects in with the next thing, planning and thinking ahead. We know that when people have Huntington's, they can often start to struggle to imagine the future, which is obviously something we all do all the time. You know, we've probably all got a rough idea in our heads what's going to happen for the rest of today, what we'll be doing. We might be wrong about that, because obviously all unexpected things can always happen. But generally, we've got a fairly good idea. If you have Huntington's, your ability to do things like that is compromised. So anything that involves that kind of looking into the future and imagining what might happen is difficult. Thanks, Eve. Sometimes when people have Huntington's, they can lack insight into the symptoms that they're experiencing, and we'll talk a little bit about that in a little bit. We know that people require extra processing time to digest information, so that might be quite a bit longer than they used to need, or that someone without Huntington's needs. So Jimmy Pollard, who I mentioned earlier, who is doing a talk for us next week, compares it to being like a timer. So, for example, if you ask someone with Huntington's a question, it sets the timer off. But and you might not get a response straight away, and you might think, well, that person hasn't heard, and so you might be tempted to ask the question again. But what really that does is set that timer back, so that person with Huntington's has to go right back to the start of the thought process again. So what we find is a lot of people with Huntington's don't get the answer out, even though they could do if they were given enough time. So a key thing really for people who are supporting people with Huntington's is to be aware of that and to give people that extra time to process information. We know that some people with Huntington's struggle to read people's facial expressions. So and that can be quite a difficult thing socially, because obviously we judge a lot of information from reading other people's faces. You know, so we can have a fairly good guess at what someone's mood is just by looking at their face. If you have Huntington's, you might start to struggle to read that kind of information. I mentioned just briefly there about lack of insight, and this connects in with unawareness. So unawareness is when someone isn't really aware of the problems that they're having. Maybe everyone else looking in from the outside can see those problems, but that person themselves isn't aware of them, can't see them. And this is caused by the changes that are happening in the brain. You know, if you think back to the brain scan just before, this affects people's ability to self-monitor. And what we mean by that is ability to look at yourself and look at maybe what needs to be done. So a kind of easy example of that is someone with Huntington's, for example, might look in the mirror and say that their hair's messy, but there might be a bit of a disconnect, and they might not then think, well, I need to brush my hair. So it can be that ability to sort of join those two bits of, you know, noticing something and joining it to an action can be difficult. because, as I mentioned earlier, people with HD can struggle with change. It can get easier to say no to things rather than get involved in activities. No, it might not mean that they really don't want to do something. It might be that they just the thought of, how do I get started on this? What do I need to, what sort of things do I need to do this activity, can get all too much. But actually, if given the right support, they might well want to do that activity if some of the thinking burden was taken away. It's quite important to know that an awareness is different from denial, because it's something we hear quite a lot. And obviously, there might be an element of denial for some people with Huntington's, but a lot of the times when people it's said of someone with Huntington's that they're in denial about the symptoms. Denial is where you do know that something's wrong, but you're pretending to yourself that it's not. An awareness is different to that. An awareness is where that person genuinely isn't seeing the problem. And that is often more the case for people with Huntington's, that people just genuinely aren't seeing the problems that they're having. So some people, when they have HD, they might accept that diagnosis, they might accept that they have Huntington's, but they may not then go on to accept when they're showing symptoms. And sometimes that can cause some difficulties. Obviously, it causes difficulty sometimes if someone needs help, but doesn't really acknowledge that, or maybe don't see that they are starting to have some symptoms that are impacting on their ability to function. And an example of that, which we see quite often, is maybe when someone continues to drive, even when perhaps they're not safe to do so, because they may not necessarily see the risks that other people are seeing. And that's not because they're in denial about it, they're just maybe genuinely not seeing how the symptoms are impacting on their ability to drive. So that's really just a little bit of a recap about some of the cognitive aspects of Huntington's. And what we're going to do now is have a look at some case studies. I'm just saying, if there's the odd thing that maybe I can see some things in the chat, we can come back to them at the end. Do you want to
I'll read this one then, John?
You want to start with this one, Eve?
Yeah, no problem at all. So we'll read this out. Jo has been living at home on her own and until recently was coping well. When her friend Sharon visited last week, it looked as if Jo had lost some weight and was wearing the same stained clothes she'd been wearing the week before. Jo has a shower over the bath, which she was able to manage until the recent change in her mobility. Sharon asked Jo whether she felt she might need a bit of help now, observing that she could see Jo was wearing the same clothes and it looked as if she had lost weight. Jo said yes. Jo received a call from a social worker a few days later. They asked how she was and she said fine. They then asked whether they could visit to carry out an assessment of Jo's care and support needs. Jo instantly said no to this. The social worker then closed the referral.
These are really just some thoughts on these case studies. These aren't definitive answers. I don't think it's possible to give definitive answers to these. It's just thoughts on them. And really, just another thing is just to mention that we've got 3 case studies, and they probably get progressively more serious. And I'm just thinking, if there's any family members on who might find that distressing, then please feel free to drop off the call if you want to. Sorry, Eve.
That's all right. So as John says, these are our thoughts. We've been looking at these for a little while. There are a few things that sort of jump out at us. First of all, it's about Jo's understanding of what the social worker wants to do. So the use of that person's language. So a care and assessment need might not be the sort of language that this lady understands. So it's about sort of modifying what you're saying when you're speaking to somebody, particularly over the phone. So a very easy reaction is to say no, and no thank you and I'm fine, and we've all heard that an awful lot in our role as working with people with Huntingtons. So it's looking at language, but also that social worker's knowledge about Huntingtons. You know, maybe that they can work alongside ourselves from the charity, or in this particular case, Joe's friend Sharon. She's also got a very good relationship with Joe, and is doing that joined up working with people that understand the person and have that rapport with her that will build some trust and hopefully get a little bit of support for this lady. So it's utilising sort of key people that are around this person and their relationship with that. And our other thoughts was that possibly that Joe's mood may be dipping a little bit, which is very common for people with Huntington's. Low mood and apathy are very frequent symptoms that we see quite early on. And actually, low mood is very treatable, as we all know, and can respond really, really well to medications. So ensuring that the clinical team that are involved supporting this lady is in place, and that those sorts of conversations have been had, and if she's on medication, is that still working at a level that we feel is helpful? Does that need to be reviewed? So those are a few thoughts that we came up with. I don't know if the other ladies on the screen have got a few. They're sitting there very quietly.
You've done a great job, Eve.
Yes, I mean, I was thinking a bit about the weight loss, and I was thinking about what John said about the trial of symptoms and how those all kind of intersect, and perhaps it is Joe struggling to go shopping now and get the food she needs in the house to ensure she is taking adequate nutrition, you know, and that maybe that's behind some of her weight loss. So is she actually struggling with the kind of cognitive demands of those tasks? And yeah, and also whether her cognition's been impacted by her weight loss, because of course we know that weight loss, if it has been a bit sudden, can exacerbate symptoms. And if Joe's friend Sharon is visiting fairly often, she might have noticed that change. You know, it might have been a few weeks ago and she's noticed, oh, she's lost a bit of weight. So could that be behind that as well? So then you could think, well, you know, do we need to help with a bit of shopping possibly, and things there that might help her to regain a bit of weight, which then could have a positive impact on her kind of being able to do certain tasks and things.
Yeah, it's also mindful of people who have infections of some sort, so either a chest infection or a UTI of some sort. They may not be able to cognitively understand them feeling unwell and being able to make up that joined up thinking that we have, but they can have a really large impact on how things are manifesting for that individual. So a sudden change in somebody is usually not a Huntington symptom, is it? It's usually related to something else going on.
I think as well, it's key, the point that we have there about helping the social worker to understand Huntington's. I mean, it was quite a quick sort of dismissal. You know, she said, I'm fine, and the social worker closed the case. If we can help social workers to understand that that is quite common with people with Huntington's, we do actually provide a booklet as well that we can give to professionals involved in supporting people with Huntington's. But it's crucial, I think, that they're aware that can happen, but we do have to be persistent and try to build that rapport and take it quite gently at first, like you said, Eve. It's important to go gently and try and get the foot in the door.
So encouraging them to see the person face to face as well. I mean, there are many benefits to Zoom. Here we are, and doing things remotely. But I think for a lot of the families we work with, when you walk in the door and see that person and see how they're coping, then that creates a very clear picture of what their struggles are and what interventions might be helpful. So it's encouraging people to actually go and do a visit or see people or have conversations with people who know this person well.
Telephone calls can be quite, you know, that when you're answering a phone, it's quite a cognitively demanding task. You've got to listen to what the person is saying. You don't know who that person is. You know, if you've got an underlying anxiety, just the answering of a phone, you know, can be a lot for somebody as well, especially if they haven't got the context of that person. And I think with Jo, you can see, you know, her friend pointing out some of her observations and then discussing those with Jo helps Jo to realise, yes, those are areas that perhaps I've got problems with, but also the relationship with her friend Sharon then helps her to kind of navigate that and feel safe doing that with somebody as well. I think it's important to feel comfortable with people, isn't it? So I think there's all that going on there as well.
It's a good example of a little bit of input, you know, just a small package of care or sort of some low-level intervention actually would make all the difference for Jo and continue to be independent and have a quality of life just with that little bit of intervention.
I was picking up, we've got a question, and I think it relates, Eve, to what you said about the language used. Someone's asking, do you have any suggestions about what language could be used instead of assessment, or how that might be put? I don't know if we've got any ideas on that, about how that might be put in a way.
Assessment sounds quite formal, doesn't it? You know, when you get a phone call, one from a social worker, that's quite a professional person in capacity, you know, and they're saying, I want to do an assessment of your health and care needs. It all sounds really official. So it's just being a bit more gentle about saying, can we come and talk about ways that might be helpful for you at home? You know, we want to keep you home, we want to keep you independent, we want to keep you safe, and we want to work with you to achieve that. And can we have that conversation? So it's just thinking about words that might be less intimidating.
Yeah, bringing up Sharon as well, because of course Sharon was instrumental in that conversation, and I was, you know, and then helping, and then it might help Jo to feel comfortable knowing, Sharon, you know, someone I know, I trust. Bringing her into the conversation could then help her to open up a little bit, because she'll know that's someone she feels comfortable with again.
I think for a lot of Huntington's families, they've obviously had experience of other family members being affected, and historically for a lot of people we work with, some of that wasn't positive. So for a lot of family members, social services and clinicians and all those sorts of people involved, they might be quite fearful of what actions they may take. So they've already got this history that may be something that's causing them some distress over people becoming involved and what that looks like. It's being able to visualize, and John touched on this earlier, you know, what does an assessment involve? What does a package of care look like? You know, and having to visualize all that and think it through in a short space of time might be a bit of a challenge for that individual.
Thank you. Just someone's asking, I read somewhere that a person could have HD their whole lives and not know. Is there a typical age of onset? Should I just answer that? I mean, I think if you know what you'll see, if you look for that, is an average person with Huntington's would start to show symptoms somewhere between the age of 30 and 50. That's kind of what you would see as an average. Should we move on to the next case study?
Great. So Terry lives alone and has been struggling to look after himself, neglecting his personal care and not preparing meals. He's lost weight. After a social work assessment, carers were arranged to support him to get washed and dressed and prepare meals. The care package of 2 calls a day has now been in place for a couple of weeks. However, when carers arrive for the morning call about 8 a.m, Terry sometimes doesn't open the door to let them in. When they do get in and offer to help him wash and get into clean clothes, he says that he is okay, or that he has already got changed, although carers can see he is wearing the same clothes as the previous day. When carers challenge this, he gets very angry. While they are there, carers offer to make Terry breakfast, but he declines. They prepare him a sandwich for lunchtime, which is usually still untouched in the fridge when they come for the call at tea time. The carers prepare him a hot evening meal, which he eats while they are there. So I guess some thoughts here. So the timing of the call, I know he said it's about 8 a.m, so we've got a rough rough idea of the timing of the calls here for Terry. But of course, we know that these don't always stay the same with care agencies. Sometimes they'll be a bit, they may come at slightly different times. So thinking of what a kind of consistent approach to care calls where possible and predictability could be really helpful to Terry here. So it may be that they'll know when certain carers are coming, and perhaps something like a whiteboard or something that Terry can look at and kind of know what to expect could be really helpful to him. So he kind of has an idea of who's coming into his home, his kind of safe space each day or twice a day. And another thing I think to think about here is, of course, routine. So routine, we know in Huntington's is really helpful. Again, it provides that kind of predictability and things, a nice rhythm to your day and your week. But 8 a.m, maybe, is this what Terry himself has chosen? Is 8 a.m. too early for Terry? Is he going to bed a bit later? Is his normal routine actually get up at 10 o'clock? And perhaps the 8 a.m. call is just does not fit with his routine and how he'd like his day today to look. So, I guess that's something to think about there. Often with care calls, you don't necessarily have the ideal time slot that you might like. So thinking, could that be changed a bit for Terry? Could be really helpful depending on what Terry thinks about the situation. And I guess another important question here is the call long enough? Is Terry feeling rushed? Are they kind of asking Terry quite a few things or trying to do things, multiple things at the same time? So as John mentioned, kind of multitasking or switching between tasks can be really demanding and very, very tiring as well. So is Terry being asked about certain things whilst the telly's on in the background? And is there, is he having to kind of switch his attention from that? There's a lot going on. That could be a bit overwhelming, a bit anxiety inducing. And again, he might just say kind of no to things or not engage with things as much because of his environment. Again, we're looking at the use of language here. What do you want for breakfast? Maybe what they're asking him, and Terry may go, "Oh, there's a lot of things I like for breakfast, but what exactly do I want? What have I got in the cupboards?" Whereas if one of the carers were to give him an option, he may then be able to select that option. So you're reducing choice to maximize choice, which kind of sounds counterproductive, but you're allowing Terry to then choose from a few selected things to help him be, kind of be in control of what he's eating and have as much say in what's going on around him in his world kind of each day. I guess another thing, maybe initiating tasks. It could, I know with the sandwich, they say the sandwich is there, they put it on the side of him. Does he then forget the sandwich is there? Or if he feels hungry, does he not think, right, I'm hungry, but I need to go and eat the sandwich because that will then stop me from feeling hungry. And also sleep pattern. I meant maybe he's not sleeping so well at night, which could be impacting his kind of ability to kind of be up and about in the morning. And is that something that he may be struggling with in terms of routine and patterns?
I think it's very much about a very solid package of care, isn't it? And those carers, and we've seen it many times in our role, where a really good package of care with sort of 3 or 4 regular carers at consistent time for an hour, not half an hour. I know a lot of the calls are usually half an hour for breakfast and a quick shower. For a lot of people we're working with, that being rushed causes them a great deal of anxiety, and it's just trying to give people opportunities in a slightly different way. So whereas we usually go in and say, would you like a shower? Actually, we need to think about the words we're using rather than giving a question that can be a yes or no answer. It's putting the shower on and your clean clothes are on the bed. Shall I go and start porridge? So it's kind of initiating the task on behalf of the individual. So they do absolutely have the choice to get in the shower or not, but it's just some of those, as Tiff says, those initiating, actually planning what I'm going to wear, is the water the right temperature, etc., and all those sort of unanswered questions that may be going around that person's head. They've been answered. Shower's on, it's warm enough, your towel's on the radiator, and your clean clothes are on your bed. And if you need a hand, give me a shout. So it's just trying to promote that person to follow the task through.
Is there anything more to say about this, or should we move on to the next one?
I was just going to say, I guess it says about where Terry gets a bit angry when the carers challenge, challenge that he's wearing the same clothes. That was the example they used in the case study. And, what's he getting angry about there? Be interesting, because is it that he actually wants to change his clothes but he can't? Is it that the carers, are not kind of giving him the right help in that moment, and that and that's then meaning he's getting angry? Or is he quite low in mood because of the changes that he's experienced, and that's causing him to get angry? And has there been a bit of a change over the coming weeks, and is that behind him, his frustrations as well?
Yeah, I suppose the other thing there, Tiff, is the way that care is putting that humiliating.
Yeah,
is he being made to feel embarrassed?
Yeah.
So there's that side of things as well.
Absolutely. Someone's just said it. You may feel that he's being judged, and I suppose if someone's observing where you're wearing the same clothes as yesterday, exactly that. If you think, well, I'm trying, but everything's just not working in the same way. It's just everything's much more clunky, and then that would be frustrating, wouldn't it? And of course, we add to the fact that sometimes people with Huntington struggle with impulse control. So not only are they really struggling to deal with that, they suddenly get angry or frustrated by something a carer said, and will come across as angry and frustrated, all in quite short amounts of time, I suppose.
I think this is where consistency with the carers is really important as well, because if they do get to know the person really well, they'll get to know their kind of their little idiosyncrasies in their behaviour, and they'll get to know, they'll be able to read the person and the sort of the unspoken things that happen when you know somebody quite well. So it is difficult within the care system for that to happen, we know, but where it does happen, it's always really beneficial for people, especially with HD, Huntington. So
personal care is such a big, intimate task, isn't it? Actually sometimes, as much as that's the goal we want to achieve for that person to be comfortable and clean, sometimes we actually have to take a few steps back and just build a bit of a relationship with that person before we start thinking about sort of helping somebody with any of their intimate care.
Rachel, should we move on to we've got the same problem with the slides.
Yeah, it's fine. I've got it on another slide here, so I can read it from that, don't worry. Okay, so this is about Martha. So Martha's family visit regularly and have previously raised concerns about her well-being. She has made friends with the local homeless community and buys them alcohol daily. Martha is no longer cooking food and is choosing to eat in pubs and cafes, although she has been asked not to return to some venues due to her appearance. Martha is unkempt, often wearing stained clothes. Her involuntary movements give the appearance that she is drunk. The property is becoming increasingly unhygienic. Clothes are all over the place, and the kitchen area has rubbish, stale food items, and used plates piling up. Martha's family only see her living room and kitchen when they visit. Martha has open sores and scratches on her body and has lost weight. Martha has adamantly refused all offers of support from outside agencies, and on the last visit, she turned her family away. Martha's family are becoming increasingly distressed about the situation. Okay, so when we got our heads together to sort of talk about Martha, it became quite obvious there's multiple things happening here which kind of all impact on each other. The discussion about the buying the alcohol for the homeless community, there could be sort of financial vulnerability there. The physical side of things is also key, and the mental side of things as well. So all of these different things, they kind of interact and they're interwoven, and it's sometimes it's quite difficult to unpick. So it's just being aware of that bigger picture, and I guess the title of this webinar about the invisible things that we need to be looking out for. So a question we would need to ask is, does Martha lack insight? Does she have the mental capacity to be able to make decisions? Can she sort of retain information and weigh up that information to know that she's making decisions that are good or not so good? We can all make unwise decisions, but is she actually able to retain information and know the sort of the pros and cons of what she's doing? So that's something we'd be wanting, be thinking about and perhaps wanting to assess. Does she have the awareness and the management of her finances? We can see here that she's buying alcohol for people on a daily basis. Well, that's going to be expensive for her. Can she actually afford to do that? Is she making herself vulnerable by doing that? If she was to suddenly stop doing that, what would the implications of that be? So we need to think about the context of her behaviour. In terms of her care and support needs, so as with the other case studies that we've already discussed, we really need to think about a team approach here. It's not just one person's responsibility. It might be a case of looking at everything that's going on and thinking, okay, well, which professionals do we need to involve here, and does there need to perhaps be a discussion to sort of work out the best way to hook her into services and to actually gain her trust and to sort of get her to engage? Because sometimes it's not always about trying to convince somebody to have insight. Sometimes it's just about getting them to actually accept help. We may never convince somebody to have insight into their difficulties, but with a bit of encouragement and a sort of gentle approach, we can maybe get them to accept that they need a bit of support with things. So the fact that she's lost weight, she's got poor nutrition, can exacerbate other symptoms. We know that she's got open sores, which is a concern as well. And pain, sometimes with HD, there can be a misinterpretation of messages. So it's being aware of that, and being quite open and upfront with people and asking questions, being quite direct sometimes. Are you in pain? So that they can give you the answers. They may not be able to articulate it particularly well. And as I've mentioned already there, it's about trying to meet the person's needs. We might never be able to get them to have that insight, but we can encourage them to just perhaps take that first step, and maybe just in one aspect of the different things that are going on here, because it's very complex. We might want to just pick one thing to start with and try and get the foot in the door with that. There's quite clearly in this case self-neglect is happening, and we would be thinking about safeguarding. I think in this situation we know that the family are concerned, and you can encourage family members to complete safeguarding. That's quite a scary word, safeguarding. So it's about unpicking what that means and actually helping the family to understand. This isn't all about sort of getting all the professionals involved and getting everybody sort of doing all the things that they need to do. It's just about making sure that Martha gets her needs met in the best possible way, and it's about exploring together how that would work. So any other thoughts, ladies or gents?
Just a combination of everything that's gone before, isn't it? It's about use of the language you're using, and particularly for this individual, there's lots of concerns, and we look at capacity and safeguarding, and there are mental health acts and all those sorts of things. Those are all really big, scary words, and we just sometimes just need to go back to basics and just let people know that we want to help, that, we want to keep them safe and independent, and these are the tools we've got to achieve that, you know, and try and get that person on board with what we all want to achieve.
Yeah, and I think sometimes as well, safeguarding is quite a frightening thing for families to consider and to contemplate. They hear that word and they think, oh, social services, you know, and it is quite frightening for people. But I think if you explain, sometimes that's a good way of actually getting the help and support that people need in a kind of non-threatening way, and encouraging families to do that themselves. It can be a really positive experience. So
yeah, absolutely. Oh, Tiff, I think you've got you unmuted.
Sorry, yes, my heater came on. Yes, I was thinking about the mental capacity as well, and mental capacity, assessing mental capacity with Huntington's. Many professionals might not have had experience of that as well. So it's part of our role there could be to help them understand Huntington's a bit more again, so that they're looking at the difficulties someone with Huntington's might be having around retaining and weighing up information to make certain decisions as well. So again, our kind of role in the background to try and help them understand that, to ensure the person with Huntington's can get what they need ultimately to be happy and safe.
So this is really just to recap a little bit on some of the things that really have come up in those. You just see there's a new message come. I'm just going to check that. Just having a sounds the message come there. It's just a message in there. I don't know if you can see it there about as a person with HD.
I think this is about having almost like an advanced plan, isn't it? Almost knowing sort of, yeah. So what the person's suggesting here is that if we knew what the person's wishes were before, we could try to enable them and help to look after them, so that we're kind of working with those choices that they have. Yeah, I think in an ideal world, absolutely, that's what we would would definitely want to do that. If we know what somebody's wishes are ahead of anything like a crisis happening, or where we notice that things are starting to go downhill, if we know what that person's preferred kind of choices are, then we could do all we can to try and encourage that to be put into place. Absolutely.
It's important to have those conversations when people are well, aren't they? You know, and I know I've done it several times, but more recently with my own parents, is knowing what their wishes and their thoughts are on how their care looks as they get older, or if they're not able to make their own decisions, and having that documented, isn't it? And we've done various webinars on sort of power of attorneys and advanced directives and those sorts of things, but it's ensuring those conversations have happened and that have been documented somewhere, so we absolutely know what people's thoughts are going forward.
Yeah, great. Yeah,
did you see the one about the pillows, John? Have you done that one?
No, do you want to just yeah, because
let's have a look. So Danny, struggling to know when to do something for someone to help without consulting, something like buying a new set of pillows or bedding as a gift, as I know it's affecting their sleep, and how that might not be the right thing to do because they'd be embarrassed or undermining their independence. Wrap it as a Christmas gift.
Yeah.
You know, sometimes we do things out of the greater good, you know, particularly for friends and family members. You know, it may be that you unwrap the pillows and say, look, I've had these at home, they don't work for me, do you want to give them a go? So it's just trying to find tactics which that person might accept the gift, and just sort of working with them in that capacity.
And that does tap in again, doesn't it, about this this really, we've got to be aware about, you know, embarrassment, and, you know, people, and work with that, and not forget about how our actions might make someone feel. So just to recap really on some of the things that some of the key points being made in amongst those 3 case studies, a key theme is I think is getting to know the person, which we know might take some time. So I think a key message is we can't necessarily just do, if you're a professional, do 1 visit and then think that was it, or that was enough, or it's persevering. It's visiting at home ideally, and keep trying. And we've got on the slide here about, you know, someone might not respond to calls or letters, but really is to keep going with that, and not just sort of send 1 letter and think, well that's it. I mean, for example, we know for a lot of people with Huntington's might not, because of the cognitive processing problems people might have, people might not open a letter. So we know that, so it's not a case of where a professional could really write 1 letter and think, well, I didn't get a response, that's it, I can close that case. You know, it's when we know how Huntington's affects people, we know we've got to persevere. And obviously, along those same lines, it's about trying different times a day. You know, some people might not open the door if you call it 9:30 in the morning, but they might open the door if you call it at 2:30. So it's thinking about those kind of things. So yeah, and again, I can see something in the chat there. Someone mentioning exactly what we've got on the slide here about using that person support network to help gain access to them, help gain their trust. And it's, you know, it might be doing joint visits with other family members, or it might be doing a joint visit with you know, other professionals. It might be the case that we can support the person by supporting the carer. If the person themselves might not accept help, we might be able to support them by supporting the person who's there, if there's a family member there who's caring for them. And that might be as good as we can do for a while. But so it's thinking about the carer and thinking about supporting them as well. Just to reiterate, we need to take time to communicate. We can't rush these things. We know that processing can be quite slowed down. We need to keep things simple. We need to keep our language simple, because processing information when you have Huntington's is hard work. It can be fatiguing. We just need to keep it 1 step at a time. We're saying at the slide here, so it might be wise in some circumstances to not focus on the Huntingtons, not talk about the Huntingtons too much. Really, the goal here isn't for people to have insight into their condition. The goal is for people to have the help that they need, and so it's encouraging people to accept that help. And it might be that talking too much about the Huntingtons might be off-putting for some people. So that having insight into Huntingtons isn't really the goal here. The goal is to encourage people to accept the help that they need. We know that change is difficult for people with Huntington's, so it might be thinking of ways to make that more acceptable, to make it so small steps. To try little things, try a little bit of help, for example, before moving on to like maybe building on that. I know that sometimes I've certainly come across situations, I'm sure a lot of people have, where a great big care package maybe has been put in for someone with Huntington's, and it's just been overwhelming. And the result of that is that that person said they don't want any of it. Where actually, maybe if that had started much smaller, even though it wouldn't have fulfilled all that person's needs to start off with, eventually it would have done. So it's working for what people find acceptable. And the last point really here is, yeah, it's just thinking about once support is in place, what we do. You know, if there's a plan so everyone knows what's happening, routine and consistency are exceptionally important for people with Huntington's, because of the thinking changes that are happening, because of not being able to imagine the future so easily. Routine and consistency take away some of the thinking effort around those kind of things. So reinforcing what the plan is, reminding people what the plan is reassuring. Communication is key, taking time to listen to what people want, to make sure that the care is what they want. and not what you know, it is something that they were going to find acceptable. Giving the person time is a key thing, and training really for those people providing care is particularly important, because often the person with Huntington's can't adapt their behaviour very easily, their thinking isn't as flexible as it used to be. It's up to everyone else around to be flexible. The key thing is don't overwhelm with choice. If we know that there's going to be changes, we need to prepare for that. So that can be quite small things. So if you're supporting someone, for example, to get washed and dressed, it's to milestone that. Say, you know, now you've washed your face. Now it's time to go and get dressed. So it's doing things in chunks, chunking activities. Yeah. Staying with a positive attitude and trying to control our own responses, even if it is quite frustrating. Keeping a log is important, because that can be helpful if there's a problem, and because sometimes when there's a problem with someone, it's not immediately apparent what the cause of it is. So keeping quite detailed sort of notes can be really helpful if trying to identify if there's a trigger. In more extreme cases, things we might be looking at, as Rachel mentioned in the case study she was talking about safeguarding, we might need to look at mental capacity, or we might need to be looking at decisions made in someone's best interest. So just for me to say again, thank you very much for joining us, and thank you for coming along today.